I'm Jack Cush with Room Now, and welcome to the RA panel from EULAR 2022. I'm joined by a group of the Room Now faculty who have a particular interest in rheumatoid arthritis, and I'd like them to introduce themselves to you. John.
I'm Jonathan Kay at UMass Chan Medical School, as you can see from my background in Worcester, Massachusetts, and it's a pleasure to be here with Jack and my colleagues.
Richard Conway from Dublin, Ireland.
And Eric.
Eric Dein from Institute of Rheumatic and Autoimmune Disease in New Jersey.
Excellent. All right, folks, what we're going to do is bring the audience up to snuff on what we thought were the key presentations from EULAR in the field of rheumatoid arthritis specifically. So why don't we begin with Richard? What really got your attention at this meeting, Richard?
I think the one that excited me the most was the Treat Earlier study, which was a intervention in pre-RA with methotrexate. And we've seen a couple of studies like this before with rituximab in the Prairie study and abatacept in the ARIA study. And I've been a real naysayer and doubter of the validity of these studies or wisdom of them. But really all people were doing was treating what was actually RA, and this theory of preventing RA by early treatment, it never really was a runner with me. But this study is slightly different. So what they did in this, it was a randomized double-blind controlled trial. There was a 1-year treatment period and then a 1-year follow-up period. Patients were randomized to either methotrexate or placebo. Methotrexate was dosed up to the maximum tolerated dose with a limit of 25 milligrams a week. All the methotrexate patients also got a single shot of IM depomedrone, methylprednisolone 120 milligrams at the start of the study. Not really sure why, but they did.
Right.
And then, so there was 236 participants overall. Primary outcome was the development of arthritis. And actually there was no influence on this. I think it was 82 versus 84% developed arthritis over the follow-up. There was a bit of a delay in the development of the arthritis in high-risk participants, but again, they all ended up in the same place. But when you looked at the actual secondary outcomes, it became really interesting. So there seemed to be this sustained benefit to this early treatment with methotrexate. So, but this was both on imaging measures, so MRI detected inflammation was less in the methotrexate group, but also on pain, morning stiffness, functional outcomes in terms of HAC. So this is really interesting to me. It seems that this early intervention with methotrexate has this kind of corresponding window of opportunity in pre-RA to what we already know exists in rheumatoid itself. And it seems that by intervening earlier in these patients, you get long-lasting benefits potentially for the rest of their disease course and seem to modulate them into a less severe version of rheumatoid arthritis if it does develop. This is really exciting for me.
So I want to give the audience a sort of visual picture of how this went. Everybody gets randomized, and if you just looked at both groups, methotrexate, placebo, the two lines are the same as far as their Kaplan-Meier plot falling off and developing RA. But if you split it up by ACPA or high-risk patients, the lines diverge, and the ACPA and high-risk patients had less progression, but in the end, they caught up, right, at the end of that year. But you're saying now that the individual parameters, the HAC and the MR inflammation and whatnot, those lines stayed divergent and parallel over the duration of the study. I found it interesting, and the author said this was the first study to suggest that there was a window of opportunity and that there was a benefit to early intervention, but it sort of gets nixed by the primary endpoint, does it not?
I'm not sure it does. I don't think it matters. I think to me, they picked the wrong primary endpoint. That was never going to work out. kind of already knew that from previous studies. And I think to some extent, the endpoint that they found is potentially even more important.
So individual components could be as impactful. I mean, ultimately, those components might be the things that we end up treating. The results were somewhat reminiscent of the old PROMPT study, which also showed separation in arms on the methotrexate versus non-treated groups, but only in seropositive patients. But in the end, it didn't matter. So I do think this is very compelling data and does argue in some ways in favor of it. I'm going to argue that the ARIA study was better at it. But Eric, John, what do you think about the study?
I think it's an important study, and it justifies treating patients with arthralgia, especially those who are seropositive, earlier with methotrexate with the potential of some benefit. We're not going to prevent the onset of rheumatoid arthritis in most patients, but as this study showed, there may be a better outcome, and these patients may have less severe disease. And we don't know down the road whether they might avoid escalating therapy to other agents or more intensive therapy. So it's a short-term study, and it doesn't look at 10 years of follow-up, but there is potential benefit. I think it's a very important study in that it looks at treating patients with arthralgia with methotrexate and looks at the potential benefit. We have to remain agnostic as to whether this is the right thing to do or not, but I would give it a thumbs up.
Eric?
Yeah, I think it, again, kind of, we used to have this, black line of you have to have synovitis in order to meet the definition. And I think, with these arthralgias, it's not all comers, but finding the patients at high risk or with antibodies. And, I use a lot of ultrasound in my practice, and whether it's ultrasound or MRI or doing things to screen these patients early or start them on medication early, I think it's starting them at the onset may have long-lasting benefits.
So I'm going to come back to all of you after I talk about the ARIA study briefly and ask you, all right, it's your mother or your mother-in-law, are you going, and they have preclinical disease, are you going to try to treat them with either methotrexate or abatacept? The ARIA study, which we presented at ACR 2021, was a 100 patient, actually 98 patients were enrolled study who were either, and they had to have MR inflammation in their hands and feet, I think. They had to be seropositive. So, but they didn't have swollen joints. They had on average like 3 tender joints and 0 swollen joints, and not much in the way of acute phase reactants, in fact. And they either received placebo or abatacept sub-Q weekly for 6 months. At the end of 6 months, there was significantly less joint inflammation and significantly less progression to RA in those that received abatacept compared to placebo. At that 6-month time point, there's another 12 months of observation off all drug that goes in. And that's what they reported here at EULAR. I didn't report the MR outcomes, but it did report that after 12 months of observation, the separation between the abatacept group and the placebo group continued, and those lines never met. And the other parameters that they were following, clinical parameters, showed improvement in the abatacept group more so than in the placebo group. So when I look at these studies, you either are not preventing any disease, or you're slowing down the progression to that diagnosis, or you're actually preventing. And to me, because the earlier study had the lines converge and ultimately people still develop RA, whereas in the ARIA study, they did not converge, they stayed separated and in fact stayed parallel. I think it was a positive prevention trial. Now, it's still a small trial, 98 patients and 18 months. We are going to wait on the much larger ARIPA study with abatacept as a proof of whether or not to do this. But if you ask me, am I going to treat my mother or mother-in-law who has arthralgias and either a positive MR or an elevated CRP, I'm just still only going to treat swelling. And if they don't have swollen joints, I'm not giving methotrexate or abatacept. But both these studies do make me think of that I might do this. So let me then ask the Richard, what would you do?
I'm going to disagree with you, Jack. I would 100% give methotrexate. And in fact, if my mother had arthralgia that was bothersome for her, had an MRI that was positive and had seropositivity, I'd be giving methotrexate and leaving her on it. I wouldn't be stopping it.
And it wouldn't change if it was your mother-in-law?
No, probably not.
Okay, good answers. Someone might be listening. John, what would you do?
I would agree with Richard. I think there's little downside to starting methotrexate. Abatacept, bit more expensive. The study's small. Both studies are small and short term. I think the jury's still out. Also, what measure do we use to detect active disease? There was an interesting presentation on the first day from Manchester where they looked at ultrasound, powered Doppler, and they also looked at DAS28ESR, and they found a discordance. And they found that there were patients who had active disease but had negative powered Doppler. So ultrasound, even though in Eric's hands it's much more sensitive than other measures in terms of detecting active disease, is not absolutely foolproof in detecting active disease. And then now a decade ago, looking at what was then the Corona database, we showed that sedimentation rate and CRP were both normal in 58% of patients with active rheumatoid arthritis by CDAI. And then in another 12 or 13%, one of the two was normal. So up to nearly 3/4 of patients with active rheumatoid arthritis have a normal level of acute phase reactant. Given that they have negative powered Doppler in some cases, it's hard to assess. So there's little downside. I'm pretty comfortable using methotrexate. Little downside in prescribing methotrexate for these patients. And as long as they don't develop toxicity or adverse symptoms, it may have benefit.
I think everyone would agree that swelling ticks the box of activity, but then how far do you go? On one hand, tenosynovitis on ultrasound is a highly predictive variable in these preclinical patients. Yet, ultrasound findings don't well predict response very well, and so it's hard to know. I think, and of course, I train in ultrasound, but I don't do it regularly. I think someone who does a lot of it still would probably want to use that information. But Eric, you get the last vote. What would you do?
Yeah, I think my mother-in-law is staying downstairs, so I have to give a good answer. I would say, I think I would also go with methotrexate. I think methotrexate is, it's the backbone of RA therapy that I think if you're going to start someone on something, I think it would be methotrexate. And I think if you see, not just a story of aches and pains, if you see, clinical, if you see synovitis or inflammation on an ultrasound or an MRI, even if it's not true joint synovitis, if they have a good story for morning stiffness, if they have antibodies, I think you do have benefit of treating them early.
I do want to remind our audience that no guidelines currently say that we should treat preclinical RA, but then again, they didn't really have any good data to go by, and we're starting to get good data. So that might change the next time we see guidelines come up. John, why don't you give us one of your favorites from the meeting? So
I think there were a number of themes at this meeting in terms of rheumatoid arthritis, one of which was lung disease, the prevalence of lung disease and the morbidity of lung disease. But another was digital medicine. And I was impressed with a presentation that was given on day 2 of the meeting from Spain, abstract OP0132 from Valencia, where the group used natural language processing and analyzed unstructured clinical data from over 2 million medical records at 6 public hospitals in 4 different communities in Spain. And they found a prevalence of rheumatoid arthritis using this methodology to be about 0.5%, which was comparable to previous studies. And then they found about 11,000 patients with rheumatoid arthritis and found a higher prevalence of interstitial lung disease than previous studies. They found a prevalence of interstitial lung disease of nearly 9%, whereas previous studies had found nearly 2% and nearly 4% as the prevalence. and they found that cigarette smoking was certainly associated with the diagnosis in 2/3 of patients. 2/3 of patients were female, as might be expected, and the mean age in those with interstitial lung disease was nearly 70 years old. So this study took advantage of natural language processing to screen thousands, hundreds of thousands, millions of medical records from a large number of patients to identify the prevalence of interstitial lung disease. But since chest x-rays weren't necessarily done in all patients, these were clinical diagnoses. So it may have been an overestimation or an underestimation of the prevalence. But this technique of natural language processing is being developed nowadays and is tremendously powerful for epidemiologic studies. This is an example of how it was used to look at interstitial lung disease, but it could be used in many different, for many different applications. An area of interest at this meeting was the safety or lack of safety of JAK inhibitors, and certainly using natural language processing to screen medical records for comorbidities and for adverse events might give a more precise indication of relationship or lack thereof between certain adverse events and certain drugs. So this abstract intrigued me. It might not have been the most important abstract at the meeting, but it certainly was one that was very interesting.
Richard, you've written about lung disease and RA in the past. What do you think of that?
Yeah, no, I think it's very interesting, and it's important data to have. And then we as John said, we have this kind of range of estimates of interstitial lung disease and rheumatoid arthritis, ranging from 2% up to higher numbers. And it seems with studies like this, and then even going back to the older data from the Mayo Clinic, are up around 8%, that it is that kind of 8 to 9% that we're talking about. So something very important in terms of numbers and obviously in terms of its severity and impact on patients as well.
Yeah. Eric, what do you think of the idea of using machine learning to guide you in your thinking about these diseases or the diagnosis of them? It seems to it's becoming a bigger player these days.
Yeah, I think it's definitely a tool that will be out there. And I think there was a great debate on telemedicine and the role of telemedicine, where they had the pros and the cons, and in the pro argument, they talked about artificial intelligence and communicating with your patient and flagging patients. And so I think this machine learning or AI is going to be, it's going to be there. And I liked the point that they made, that it's there, and it's there in the private sector, and it's going to be a part. So I think we need to learn how to accept it and how to use it. But I think especially for a research perspective, it's a tool. I don't think it's going to replace everything in our research, but it's a tool that I think can definitely shine a light and do some of these big, large population studies that we couldn't do by going through the medical records.
Yeah. So in looking at this data, first off, I have to say I'm big time in favor of artificial intelligence, machine learning. Moneyball, I wrote a blog about it, still my favorite blog, because I think that's where the answers are in the future. But to be fair, balanced, I looked up important quotes about machine learning, deep learning, AI, and I found these two. One, machine learning is no substitute for natural stupidity, number one. And the second one is, if your mother says, are you going to drop off the bridge like the rest of your friends? If you're a machine learning person, you're going to say yes. So the idea is that there is something within machine learning that might miss the obvious, and it is going to take, obviously, your wisdom and judgment to figure out how that factors into what you may be doing. But like John, just like you said, this whole idea is being applied to clinics where we're not making early diagnosis, like spondyloarthritis, right? And it said 7 to 10 years to make a diagnosis there. Well, they could identify them a whole lot earlier through basically machine learning and natural language processing. So I think it is an advance. We need to see if it gets clinical application going forward.
Well, the big problem is that natural language processing is dependent upon the language that's in the medical records. And if people don't write good notes in medical records, or are not precise or are imprecise, then natural language processing is not going to substitute for that or overcome that limitation.
True. Very true. Eric, what's one of your favorites in the meeting?
Yeah, I thought another big topic of conversation from the meeting is RA and more comorbidities. And I think when we look at what are the big morbidities, there's been a lot of discussion recently. Obviously, I think we all know that depression is important. Depression plays an outcome, but how much of an extent that is, I think is something that is surprising us when we look at data on this. So there's an oral presentation 0067 that looked at incident depression risk of morbidity mortality in rheumatoid arthritis, and obviously that's as key of an endpoint as we can have. And what we found was a 6-time risk of death in patients with rheumatoid arthritis. So I thought this was a huge takeaway, major number. There was a lot of discussion about the methods that when they did this was based on a population-based study where they defined depression as the first filling of antidepressants. So they were looking specifically at incident depression, and they looked at if they had their first antidepressant fill. And obviously we know that whether or not you take antidepressant medicines doesn't mean you have depression, doesn't mean it's capturing everyone, doesn't mean it's truly an incident diagnosis. There's obviously a lot of noise of that, of things like duloxetine or medications that may be treating active RA or active neuropathic pain. So there's definitely some noise. They talked about that they validated it looking at ICD codes. So they did kind of dig into the methods a little bit. I think when they come up with a paper, they'll tell us a little bit more there about some of the other findings. But I think regardless of how you look at it, the fact that patients that are on an antidepressant have a 6 times higher rate of death. And this was largest in the patients that were under 55 years old. So
did they report what the causes of death were within that?
They didn't. No.
Yeah. So it's obviously a marker, maybe surrogate for comorbidities that kill, but it was a scary presentation actually, and I got my attention, and I was worried that there was just confounders, but they confirmed it by those ICD-10 codes. So I think this issue came up a lot in our Room Now Live meeting and other things. We are not good at asking the question, do you have depression, or screening for depression in our clinics. We have issues of comorbidity concerns, and we use that to certain advantages, but we're not so good at managing comorbidities. But this might be something where we really should have at least one question: are you depressed? Or do a modified Beck inventory, or there's another tool called a PHQ or something along those lines. It's a short questionnaire, but I don't know. Has anybody addressed this at all right now in your practice? I certainly don't.
But if you go back to the 1990s and Ted Pincus, the Rapid 3 has caught on. But if you look at his original questionnaire, there were 3 questions after those 10 questions that comprised the Rapid 3, and they were, do you have any difficulty dealing with feelings of anxiety or depression? That was one of them. So Ted was screening for depression way back. And if you hand out that questionnaire, not only is there that, but on the reverse side, there's the 50-item review of systems, and I think it's the Columbia depression scale. If you check off all of them, that's certainly depression and nothing else. So that questionnaire, if people would go back to it, was a good screening tool or at least open the door for discussion about depression.
Yeah. Mine is one checkbox amongst 37 checkboxes of what's bothering you now. And it tends to be more of a marker of fibromyalgia, but I think even we know fibromyalgia patients don't respond well. They have lots of problems. I don't know if they have higher death rates though. Richard, how do you address this?
Not very well, Jack, to be honest. And I think it's something we all need to address, because I mean, these results are shocking. There's a 6-fold increase, and we can talk all we want about all the caveats, but if this was anything else, if this was cardiovascular disease with that association, God forbid if it was one of our drugs with that association, we would be up in arms over it. But because it's depression, people don't really give it the attention it deserves, and I think we need to be better at that.
Yeah.
But if you look at this study, it's the treatment of depression that's associated with the
the antidepressants.
People under the age of 55. So the study needs to be repeated, looking at depression without treatment versus depression with treatment. You could say that pain is a surrogate for active disease, and active disease is a predictor of mortality, malignancy, and so on in rheumatoid arthritis. With cardiovascular disease, the studies point to treating cardiovascular disease to reduce mortality. But here, mortality is associated with the treatment for depression. So I'm not sure what to make of this.
Yeah. Well, it's something we got to keep our eye on and probably incorporate into our practices. I want to go to another theme, and that was steroids. Steroids were prominent, mainly with the presentation by Dr. Martin Boers of the Gloria study, which has been going on for some time now. And the Gloria study is a 2-year study of people over age 65 who are given 5 milligrams of prednisolone or placebo and are followed prospectively. Again, it's an older group. They did not meet their target enrollment, and they changed some of their statistical analyses along the way. But in the end, the patients who were on steroids versus those that were not had a clinical benefit and a radiographic benefit. And he showed the data in multiple ways, but he showed lines, diverging and being different. Now, to be fair, these patients didn't have very severely active RA going in, and the magnitude of DAS 28 benefit was minus 0.37. And if you looked at the best possible candidates, worst possible patients, most compliant patients, the benefit was minus 0.62, which is at the limits of what maybe an MCID or minimally clinically important number is for the DAS 28. So, and then the X-ray benefit, I think, was like 1.3 units, but that's on a sharp van der Heide scale of up to 440 units. So the question is, was the magnitude of clinical and radiographic benefit worth the harm? And there was, in hazard ratio, a 24% increase in harm, and most of that was made up of by infection, and mainly non-serious infection, not serious infections. There was not presented, but there was a difference in fracture rates between those on steroids and those not in the short-term study. So to me, it seemed like it was, what glass half empty, glass half full. If you love steroids, you're going to like this data. If you don't and hate them, you're going to like this data. And this is important because then Joseph Smolin presented the EULAR guidelines and spent almost 10 minutes discussing the EULAR position, which is in contrast to the ACR position on steroids. The ACR position says, don't use steroids, and if you must, just use them a little bit and for as short a period as possible, but don't use steroids, use more methotrexate. EULAR says, their research says you can use it, and their research says that 80% of patients who start steroids as bridge therapy are off of it within 1 year, and that there are significant clinical benefits to that, not radiographic, but clinical benefits to that, and that they just changed their guideline to say it's okay to use bridge steroids, and they just added the line to taper and discontinue with the idea that everybody, but so now we're left with an ACR versus EULAR opinion on steroids, and we're also left with a Martin Boers versus Jack Cush opinion on steroids. And the question is, where does the audience lie? My colleague and friend Catherine Dow, I think, did a Twitter poll and asked the audience, the rheumatologists, where do they belong? Are they in favor of the EULAR position or the ACR position? And I think she said that more were in favor of the EULAR position. So how did you guys take all this data? Let's start with John.
So I would say, well, the data are clearly divergent in terms of the guidelines. I would say ask the patient. And when you have a patient with active disease and you start them on methotrexate, it's going to take a little bit of time for them to derive clinical benefit. And during that period of time, the patients are quite uncomfortable. So I will give a 20 days worth of a tapering course of prednisone to make them feel better and tide them over until the methotrexate starts to work. Certainly, there's a downside to prednisone in terms of its toxicities, long-term toxicities, even with short-term dosing and comorbidities. But if you poll the patients rather than the rheumatologists, I bet that the patients would be largely in favor of short-term glucocorticoid therapy.
So steroids with an expiration date. Eric, what do you do?
Absolutely. I was just about to say the same thing. I think it comes down to function and the patient. If they can't work, if it's inhibiting their ability to function, then I give steroids. But I do exactly that. I think you cannot do, let's give you 5 milligrams and we're going to taper you off of it, because they'll have it at home. They'll continue to take it as needed. And that's what's against both of the guidelines. And so if they need steroids, then I will give them steroids. If they do not need it, I will stay away from it. But I'll say, this is the course, there's only this many tablets. And then, if there's issues from there, we'll have to address them. But the goal at that point is to start a steroid sparing medicine.
Richard, do the new EULAR updated guidelines and the Gloria study change your practice at all?
Oh, you're going to set me off on a rant, Jack, about the Gloria study, because it's not the study itself, but the way it's being presented annoys me quite a lot. Like they've even changed the title of it at this presentation to specifically say the favorable benefit of using low-dose steroids. And I think you've described the data very well. I don't think it particularly shows that. I think the other thing to remember about that, these patients, they were going in with their mean DAS of about 4.5. Only 14% of them had been on biologics. And they're almost portraying this study as either this low-dose steroid or nothing, whereas actually we have lots of other treatment options that are a hell of a lot safer than long-term steroids, I would say.
Yeah.
And in terms of the EULAR guidelines, I would, like John, I'm kind of almost, my practice is in between the ACR and the EULAR guidelines. I give most, but not all patients a few weeks of steroids at the start, but no longer than that.
Yeah. All right. I like that discussion, because I think it helps the audience to, in their consideration of this kind of data and what they may do in their practice. All right, we have a little bit of time left. Let's do sort of a lightning round, quick hits on something you thought was a good takeaway for the audience to know about. Richard, do you have something?
I have a bit of the weird and wonderful, and that was the study by Pernell et al. Of ice cryotherapy. And this was an animal model of adjuvant-induced arthritis. So they put ice onto the joints of rats, and they found it alleviated the arthritis symptoms. But actually, much more interesting, it also reduced aortic inflammation in the rats, suggesting that this simple local treatment approach had systemic benefits for this. And whether this will translate into the much larger organism that is a human, I don't know, but it's I thought it was very interesting.
I think it would. I'm waiting for the study where RA flares are going to be treated with 90 seconds of cryotherapy, 3 days in a row, as opposed to using steroids. That's the study I want to see. But you got to start somewhere. Let's start with a rat. John?
So there were a bunch of presentations about real-world safety data of JAK inhibitors compared to TNF inhibitors. And there was one that really intrigued me, oral presentation 0258, which was an analysis of the Digibase database of individual case safety reports. This is a WHO spontaneous reporting database. And we all know the limitation of spontaneous reports. I mean, how many times when a patient has an adverse event associated with a drug do you write to the FDA or to another regulatory agency? But this looked at these spontaneous reports between 2011 and 2022. And over these 12 years, there were nearly 300,000 reports filed about adverse events occurring in rheumatoid arthritis patients treated with either a JAK inhibitor or a TNF inhibitor. And over 4,000 of these reported a major cardiovascular adverse event, and over 1,400 reported a venous thromboembolic event. So there were lots of reports. And they found by analyzing this that the use of JAK inhibitors was significantly associated with an increased risk of venous thromboembolic event reporting compared to that with the use of TNF inhibitors. There was no overall increase in the risk of major adverse cardiovascular event reports, but the risk of MACE reporting by physicians, and specifically that of myocardial infarctions, was significantly associated with the use of JAK inhibitors compared to that of TNF inhibitors. And then they looked to see whether this was just an effect of the FDA alert that was issued in 2021 about the risk of major adverse cardiovascular events and venous thromboembolic events with JAK inhibitors. So they looked at the year 2020, and they found that there were significant associations for both adverse events with JAK inhibitor use detected the year before this FDA alert was issued. So it wasn't just that there were more reports because people were aware of this adverse event association. So I thought that this was really interesting because I've always been skeptical about analyses of spontaneous reporting databases as a measure of drug safety because of the spontaneous and sporadic nature of these reports. But this analysis of the Digibase database was quite impressive and seemed to correlate with what we've been learning using other approaches.
And this is what we have to look at, given the scare, if you will, afforded by the oral surveillance study last year. Some rheumatologists have been, most rheumatologists haven't, I don't think have been in a major way affected by this. Some have been. I can tell you dermatology, where they're getting all this new indication with JAK inhibitors, that most of them are very afraid of using JAK inhibitors based on this data and the label, box label warnings that have come out. And that's going to affect their patients who, with atopic dermatitis and alopecia areata and these new indications. So we do need to fall back on this, these larger data sets to get a true read on who's at risk. Eric, you got a quickie?
Yeah, so I was actually in clinic today, and a patient brought up to me at the very end of the clinic saying, I have a question. I have decreased sexual performance with my partner, and is that related to my rheumatoid arthritis? And I saw a presentation over the EULAR conference, OP0139, which looked at just that. And so it was a study where they did the CSFQ-14 questionnaire, and they looked at 5 different domains in that questionnaire, looking at things ranging from sexual drive and sexual performance. And it showed across the board that there was a higher sexual dysfunction in rheumatoid arthritis and psoriatic arthritis, nearly 50% of patients with RA, 30% in PSA versus 6% in a control group without autoimmune disease. So there's a lot of conversation about potential confounders of this trial as to response bias and role of steroids versus role of inflammatory disease. But I think those numbers also are interesting, and we should be talking about depression with our patients, or should we be talking about this as well? But I think it's at least something that we should be validating, that they're concerned and that there probably is something related to either the disease or the treatment of the disease.
The big thing these days is shared decision-making, where you're having a discussion with patients about some of these difficult things, and the cornerstone of shared decision-making are decision aids and educational materials. And I think if someone wanted to make $1 bazillion, that they should get into that business. These decision aids and educational materials that we can give to our patients. It's one thing for you to talk about that, Eric, but now what's the 4-step plan that individual can overcome some of their concerns about performance or getting an erection or whatever the issue is going to be, without us doing, it's been seen, shrug the shoulders, and here's a consult to somebody else who probably is not going to be as effective at it as you. So I'm really glad you brought that one up. My last one was a study, an interesting study from the Spanish registry, Brazilian registry, BioBata Brazil, looking at antimalarials in patients on biologics or targeted synthetics, showing that if you look at the patients who are on antimalarials versus those that are not, and again, everybody's taking either a JAK inhibitor or a biologic, that the ones on hydroxychloroquine had better drug durability, less adverse events, less serious adverse events, less serious infections, and I'm saying less, I mean significantly less hepatic AEs. I'm not sure what that really is. And they trended towards lower glucose and lower lipid levels, which is what is a well-known effect of hydroxychloroquine. The one thing you'd like to have seen would have been less cardiovascular events, because that's been reported with hydroxychloroquine use. But remember, these people are already on drugs that probably decrease inflammation enough that it would lower cardiovascular events, and maybe the hydroxychloroquine. So again, this is one of these reports that basically makes out that drug that I've been making fun of for so many years as probably being one of the most powerful drugs that we have in rheumatology. Anyway, I want to thank our panel for a really interesting discussion and covering a really wide range of important topics at EULAR on rheumatoid arthritis. Tune in for more of these panels on Rheum Now. Good night, all.
Good night.